Everyone for being here. I wish the whole hospital was here. I want you to fasten your seatbelts because we're going to try and give you a lot of information in an hour. But I want you to know is that if we were here for a week, 10 hours a day, we would be unable to impart all the information I'd like to provide. And one thing I'd like to share with you, and this is a truism, it takes us almost as much skill to help somebody die as it is to keep them alive. So the title here, as you can see, is Challenging Symptoms Management, End of Life. It's going to be a potpourri of various subjects here. And I'll be speaking today, Eugene, Dr. Smith, and Dorothy, who everyone knows.
And please ask questions in the middle, like hoping to make it a little interactive.
So palliative care is not just goals of care, advanced directives, but actually when employed appropriately is expert symptom management. And we can address pretty much all the symptoms that you see on there. The truth is, the better a patient feels, the better they do, the longer they live, the better the outcomes. I can tell you, it makes sense, right? Suffering is going to expedite all the negative things going on here. However, with proper symptom management, we can give them a reprieve and improve their quality of life. And these are some of the topics we're going to get on here briefly. Pain. And we're talking cancer here. Pain in itself is actually a huge stress response physiologically. It affects every system, every organ and body. There's actually a discernible signal toward increased mortality in the context of somebody who's in pain. I can tell you when pain is unabated, there's an erosion, not of the individual only, but physiologically. There's a chipping away here that occurs with pain. What's interesting is, in context, but whenever opiates are actually required or warranted, I can tell you that often these patients are going to do better, live longer, so on and so forth. When somebody's in pain, they're not eating, they're not being active, they're not doing the type of things that affect those outcomes we hope to achieve. In the context of cancer or a lot of syndromes where opiates are appropriate, I can tell you that a patient's going to live longer, do better with these opiates. If you think about the stress response, there was two groups here with compassionate extubation. The families were letting these respective patients go. One group had opiates infusing for an extended period of time. The other group had no opiates. The group with the opiates, on average, status post the extubation, lived on average 3.5 hours longer than that other group. And when you consider the stress response, it makes sense. Acutely, if I put opiates there, end of life, and I'm managing them just at the last minute, of course the opiates are going to push. Objectives. I'm just going to go past that because we have a lot of information. Okay. Adjuvant medications. There's something called multimodal. You've heard this term before. It means a variety of medications. In the body, it's like 40 potential targets for these pain medications that were provided. Say I'm giving oxycodone. So you know about mu, kappa, delta, so on and so forth. We're hitting maybe 5 or 6 of these potential pain targets. However, if I employ the antidepressants, which can be superior to neuropathic pain, the anticonvulsants, so on and so forth, not only covering those 6 areas with the oxycodone, but I'm covering a lot of territory. And actually, together with somebody's chemistry, it can be magical when ideally you marry up the right medications with the right individual. And Tylenol, lowly Tylenol, amazing, amazing drug. So I want to tell you, Tylenol, every 8 hours standing or something like that, it potentiates any other medications that come in its mix. Once Tylenol has a steady blood level on a continuous basis, it means oxycodone, whatever other medications that come in the mix are going to get potentiated. It also works with pain itself, with the prostaglandins and pain signaling. Tylenol, one thing is interesting, weakness and fatigue is actually protective end of life, where these patients are not mentating or what's about to occur, right? However, there's 20% of the population will have existential distress. They know they're going to die. Things are winding down. Tylenol, every 8 hours, high dose, can really ameliorate that existential distress. And you can certainly, in your various practice, when you see somebody struggling here with, and actually there's an anxiolytic aspect to Tylenol as well. And again, the more the mix of medications together, the better the outcome. non-pharmacological treatments. I gotta tell you, physical therapy, there's a place for it. In pain management, it's critically important. Somebody's in pain because their back hurts, you gotta get them out of the bed, sitting in a chair and being active. Because you can lose 1.5% muscle mass a day just by laying in bed. It makes everything worse, including their back pain. And the key is when somebody's active, there's an anti-inflammatory aspect, body naturally puts itself back together, nervous system is rewired, and the pain threshold is raised. That's how you get the outcomes. However, end of life, be very careful about cajoling or pushing somebody to get out of the bed. Because actually, with the best of intentions, we can cause harm and induce distress. If the patient end of life is willing to get out of bed, good. If they resist, I'm telling you, for the most part, it's okay. It's the same thing with food, right? You've seen this before. If they want to eat, good. If they don't want to eat, you got to respect that because they're telling you what their physiologically what their body's needs and requirements are. Shortness of breath. I think pretty much most of you in this room have seen that in various forms or another. The big question here: yes or no? Come on, guys.
Yes.
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 Yeah. When we provide opiates, it actually reduces preload and afterload. It opens up the bronchioles, and it mitigates the sensation of breathlessness. Okay? A lot of these patients, when it's profound, right? Physiologically, it's almost like you're running around the hospital or walking quickly on a continuous basis. Could you imagine that? And some of these patients are in such dire straits that the metaphor is almost like they're breathing out of a straw. Can you imagine that for inspiration and exploration? So I can tell you very quickly, if I have somebody who's struggling respiratory-wise, you can see those opiates coming on. However, if the opiates are not enough, you'll see me do palliative sedation, which the good doctor is going to talk about. And I think some of you in this room have seen that. Non-opiate treatments. And we know, if somebody's on palliative care or hospice, we never ever cease to treat. We're always going to manage whatever symptoms present themselves. I got to tell you, in the context of cancer, I love steroids. Dexamethasone. Somebody in the last 3 months of life, I love having those steroids on, for the most part. It gives a sense of well-being. It gives them a nice boost. It helps with pain or inflammation, also can give them some appetite as well. Very, very good for nausea. And I like when I have a symptom that I can use one medication for a variety of symptoms. Agitation, delirium. You know, this is a classic. Somebody's elderly, they're in pain. And I'm saying that, you know, we need to give some opiates, not the Ativan. The classic is, I go there, and then often, more times than not, providing the opiates can give a measure of relief where the agitation can kind of dissipate itself a little bit. And I was going to joke, for any of these issues here, always call Dorothy. She can help with it. She's like the fire hydrant for me. I'm sorry. So, okay guys, the drug of choice. The drug of choice for somebody with delirium, what's the right answer? What? Say it louder.
C.
Did you say the word for me?
Hello.
Thank you, I love you. It's not... Oh, no, don't do that. So the truth is, Ativan, when I was in another hospital, they were giving Ativan for agitation as well, wrong medication. Often what you get with the elderly or people who are end of life is you give the Ativan, you can get paradoxical reaction where the Ativan is precipitating, contributing to their agitation. So Haldol is the gold standard. I like using Haldol a lot, not just for agitation, but for nausea. It's a potent dopamine antagonist for nausea. But actually, Haldol is less sedating than Ativan. So, you know, often I'm with a patient, I don't want to ton them. You with me with these medications whenever you give them a chance? So sometimes I'll use that as a strategy as well with the opiates and everything else because I'm trying to find even keel here. Anxiety. You know, for me, it's higher than 25%, to be honest with you. And in our pain patients as well, I can tell you that often in the pain patients, often anxiety, depression are part and parcel of somebody who has chronic illnesses. Not just pain, but you know, those with undergoing dialysis or chronic issues one way or the As a strategy in pain management, I use, you see me use clonazepam a lot. It's a utility benzo. It's like a truck driver, somebody once said. It's not highly euphoric, but it's effective. And often when somebody is in pain, I start utilizing the benzos. It's allowed me to kind of minimize the use of opiates that I'm using, because in the context of anxiety, it revs everything up physiologically. And with the adjuvants of using these anxiolytics, it kind of helps for a more even keel. I gotta say this, I really dislike Xanax. I'm sorry, I shouldn't even say that. It's the crack cocaine of benzos. I wish it was never formulated. Is it always appropriate to treat fever in a dying patient? Now, this is a mixed bag. My team doesn't know what I'm gonna say, by the way. Normally it is. However, if somebody is actively dying, high temperatures is expected. No. But you should always treat fever, okay? And you know there's prostaglandins involved with Tylenol, as you know, so that'll help.
And when you say treat fevers, you're not referring to stop them on triple antibiotics and blood cultures. You're
You
just
guys weren't
saying
thinking about
symptoms.
treat. We're talking, okay,
Okay,
disregard.
clarify.
Right. Tylenol.
We're talking Tylenol
Tylenol.
here. Okay, yeah, very good. And you know, really, we shouldn't be really, I mean, I don't want to go against hospital policy, but really, it's hot to touch. It's you know, I know there's less invasive methods of taking somebody's temperature, but really, for the most part, if somebody's hot to touch, that was always something I went by when it came to blood. Nausea, vomiting. I did this for somebody in the room right now. I'm not going to say who. It's interesting, I told this to a family member yesterday, and she says, I love Zofran. So I'll be very careful with sharing those words. Etiology, it could be multifactorial. I love that word. Let me go back to this for a second. So besides Zofran, dexamethasone, I told you, right? Ativan can help with nauseous type of things, but sedating. Haldol is a potent dopamine antagonist. And you know, the truth is, when we walk in there, I have no conceived notion of what I'm going to provide for this patient. It's not until I go in the room, I spend some time with the patient that somehow will come up with whatever the most appropriate symptom management. And remember, we're continuing to treat these patients even though they're in hospice. What's the right answer? We end the torture, ready? Over 300, 300 above. Okay? I think that's really an important guideline. Hiccups. You know, there's a fail-safe medication that we provide sometimes for hiccups. You ready? Thorazine. But I'm not going there unless we have to. There's a variety of medications that can help with that. And I've seen that at my other hospital that was intractable for days. Can you imagine? And we're talking quality of life here. So, like all these other symptoms, it's important to be a little aggressive if I have to. And the point is, you can get involved, provide the medications, even though they're sedating, and hopefully you settle the storm, then you can back off from the medications that you're providing. That's a strategy. Your nurses, most of your nurses, they can't get away from constipation. 75%.
Is it that high?
Yeah.
Wow.
And can I tell you the truth, there's so many different studies out there, you got to kind of throw your darts someplace, but for the most part, it's really super high. Yeah. And you know these opiates, right, they impact motility. And the key is fluids and being active, and how many of our hospice patients end up like palliative care are just not, you know, providing that. And you know it can be life-threatening, right? I've seen, I'm sure, I've seen somebody dying secondary to it. So if you're in school and you saw the, what would be your guess on that test-taking technique?
Dr. Levinson stopped labor and delivery.
The key word all, it doesn't, no. But there is a place for it.
Dr. Levinson staff, labor and delivery.
I'm sorry. Sure, yeah. It's all about symptom management, quality of life, whatever symptoms present themselves. Treatment. The bottom, opioid rotation. The classic for me, I had somebody on a PCA of morphine and they're struggling with nausea, pruritus, yada, yada, yada. And then they kept the morphine going and they were using other modalities to help with the nausea. The best course would have been to go rotate to another opioid. And often, if I get involved, I'm probably going to use more than one of these medications on there. Low dose, but together, like using concomitant different medications together. Who hasn't witnessed this, right? What's that one term they use in this scenario? Death rattle? I hate that. There's another more appropriate term for it, but it's not coming to me right now. I can tell you that, and how they do these studies, that it's not impactful to the patient, the human being who's experiencing this,